Okay, and for our research presentation today, it's my honor to introduce our speaker, Dr. Octavia Bane. She did her undergraduate training at the University of Chicago and obtained her PhD from Northwestern. She's been a member of the Tally Lab since 2013, where her research has focused on the non-invasive study of perfusion in the liver and the kidney, and of intratumoral hypoxia and perfusion in HCC. She's really become an expert in protocol development and optimization for quantitative methods and for data acquisition and advanced analysis. And it's my honor to introduce her presentation. She'll be presenting Multiparametric MRI of renal transplant, preliminary comparisons of advanced MRI parameters in renal transplant patients with stable allograft function and chronic allograft dysfunction with established fibrosis.
Thank you for the introduction. Today I'll be talking about examining renal allograft dysfunction with multiparametric functional MRI. And this is a pilot study that's supported by several pharma companies as well as by the Society of Abdominal Radiology and the NIH. 30 to 40% of renal transplant recipients will experience at least one episode of allograft dysfunction. And these episodes of dysfunction are caused by immune factors, as in acute and chronic rejection, or by non-immune factors such as drug toxicity and viral infections. And all these insults and injuries culminate in irreversible injury to the tubular epithelial cells and the development of interstitial fibrosis and tubular atrophy, which has been associated with progression of renal dysfunction and is predictive of survival of the transplant. So definitive diagnosis of IFTA is very important, and right now the clinical standard for this diagnosis is percutaneous biopsy, which is invasive, it's prone to sampling error and to inter-observer variability. The limitations in existing diagnosis methods are a barrier to optimized patient management, to prediction of outcomes, and I would say are even a barrier to clinical trials for potential drug therapies that could slow down the progression of fibrosis. Multiparametric MRI is an attractive alternative or an attractive complement to biopsy because it has the capability to quantify renal function using advanced sequences. Functional MRI can provide insight in the function of the whole kidney or of its compartments. So the objectives of our pilot study were to develop and validate such a quantitative MpMRI protocol in patients with renal transplants. We sought to quantify parameters in patients with functional and fibrotic renal transplants, and we assessed the repeatability of MRI measurements and tested inter-observer variability. We will use these findings from the pilot study to design future larger studies to validate functional MRI as a complement to biopsies, as a non-invasive form of biopsy. This was a prospective study. We enrolled 25 patients, 15 with functional allografts and 10 with chronic dysfunction and fibrosis. 4 patients also underwent repeat visits, test-retest MRI. Normal function was defined as less than 25% change in creatinine over 3 months and the GFR over 45 milliliters per minute. Patients with more than 25% change in creatinine were considered to have chronic dysfunction, and in this patient cohort, all had biopsy-proven fibrosis, with biopsy performed within 3 months of MRI. Our MpMRI protocol consisted of several methods. I will not talk about all of them here. Some have been presented in posters that you can see in the poster hall. So my abstract covers intravoxel incoherent motion diffusion, which can quantify diffusion properties as well as microperfusion in tissue. Diffusion tensor imaging, which examines tissue architecture. Blood oxygen level dependent, or BOLD, which can indirectly quantify renal oxygen demand in the kidney, especially in the medulla. And we also looked at T1, which was shown to correlate with inflammation and edema in the kidney. This is a quick overview of our protocol. We imaged at 1.5 Tesla. So for diffusion, we used an EPI sequence with 9 B values, including small b values for more sensitivity to the perfusion effect. For DTI, we employed 6 diffusion directions, and for BOLD, we had 12 echo times, with the last echo time to correspond roughly to the T2 star of the cortex. For T1, this is pre-contrast native T1 measurement. We used the variable flip angle sequence. We also did dynamic contrast enhanced MRI and MR elastography in this patient cohort, but these will not be described in this abstract. So images from all the modalities were reviewed in OSIRIX, and motion correction through co-registration in special co-registration software was performed as needed. The ROI's regions of interest were placed in the cortex and the medulla at the upper, middle, and lower renal pole in 2 middle slices by an expert body radiologist. And we also did inter-observer evaluation in 10 patients with normal renal function. With this ROI analysis, we tried to model what happens during biopsy, because usually the biopsy samples are taken at one of the renal poles. And quantitative parameters were extracted from ROI signal with custom scripts written in MATLAB. So for the diffusion analysis, we looked at the IVIM parameters, true molecular diffusion, D star or pseudo diffusion, which quantifies the perfusion effect on diffusion, PF or perfusion fraction, so a measure of microvascular perfusion, and we also looked at the apparent diffusion coefficient, which reflects combined water diffusion and capillary perfusion. So with DTI, we looked at fractional anisotropy, which is a measure of the preferred direction of water diffusion, so which diffusion can be anisotropic, in this case FA is 0, or in a preferred direction with an FA of 1. So we used the FA maps calculated on the scanner and the motion compensation strategies already built into the sequence, into the post-processing. Previous studies have shown sparsing of tract density on diffusion tractography images in patients with renal dysfunction. And also we expect significant differences in FA. For the BOLD experiments, we looked at baseline. We did not do a physiological challenge, though that's been done in the literature before, because it's sufficient to look at differences in cortical or medullary R2 star between the healthy and the dysfunctional group. T1 is a basic contrast, but here we show clear sensitivity, clear loss of corticomedullary differentiation on the T1 maps in the patient with fibrosis. And previous publications have shown it's sensitive to edema and to inflammation. 14 patients in our cohort, of which 4 with stable function, had biopsy within 1 year of the MRI exam. And the biopsy samples were stained using Mason trichrome and Jones silver stainings, which are routinely performed at Mount Sinai as part of standard of care. And they were clinically assessed by an expert pathologist using the Banff classification. So we will focus on the degree of cortical interstitial fibrosis, the degree of cortical tubular atrophy, and a score for inflammation in areas of interstitial fibrosis and tubular atrophy. In addition to the qualitative pathology analysis, we performed quantitative pathology on digitized slides, digitized at 220 times magnification. And after exclusion of the medulla, of the glomeruli, and the large vessel, we performed automatic analysis of stained tissue fraction, as shown here in the example with a functional allograft and a fibrotic allograft. The Banff scores seen in our patient cohort covered the whole range of scores, but were biased towards moderate fibrosis and moderate tubular atrophy. So more patients had a moderate degree of fibrosis. IVIM parameters showed robust test-retest repeatability for true diffusion and for ADC, but less robust repeatability and inter-observer reproducibility for the perfusion fraction and for D star. And we observed significant decrease in the true diffusion and in ADC, both in the cortex and the medulla for the group of patients with fibrosis. We also wanted to examine the loss of corticomedullary differentiation on ADC, and we looked at delta ADC between cortex and medulla, but we did not see any significant differences between the groups. The fractional anisotropy parameter, or FA, was robust for test-retest repeatability, as shown by a CV under 5%, and also for inter-observer repeatability. But unfortunately, we did not see differences between the functional and the fibrotic group. BOLD was somewhat less robust on test-retest in the cortex, as shown by a coefficient of variation approaching 15%, and we did not see differences between the groups. So for T1, the measurements were robust, and we saw a prolonged T1 in the cortex of the patients with fibrosis. and loss of corticomedullary differentiation as reflected in delta T1 differences. Two parameters were correlated with pathology scores, which was the cortex true diffusion coefficient showed a strong negative correlation to interstitial fibrosis, which is expected. So we expect to see restricted diffusion with collagen deposition in fibrosis. And T1 was positively correlated to tubular atrophy, which is expected because tubular atrophy would be associated with edema and inflammation, and these would prolong T1. So in summary, we have established a feasible MpMRI protocol for assessment of renal allografts. We also examined repeatability, and we observed good test-retest and inter-observer repeatability for R2 star, for FA, for most diffusion parameters, but modest repeatability for perfusion fraction and D star. The reduction in the diffusion parameters and the increase in T1 is consistent with other observations in renal fibrosis in human and in animal studies. So we would expect to see decreased water diffusion with increased interstitial fibrosis, and also increased T1 with increasing TA and inflammation. Our study had some limitations, namely that biopsies were not acquired in all patients, were not acquired same day as the MRI, and we did not do serious red staining for collagen quantification. This is a more popular method in the literature. However, the slides can be retrospectively stained with Sirius, and this can be examined as well. So the premise of our research was that MpMRI provides complementary information on pathophysiological processes that would affect vascular perfusion, tubular flow, and could reflect inflammation and fibrosis. We also sought to examine the test-retest repeatability of MpMRI parameters and found that test-retest and inter-observer repeatability is very variable among quantitative, diffusion, and perfusion parameters. And we identified IVIM, diffusion, and T1 parameters that are sensitive to fibrosis. So from this study, we would like to use multiparametric MRI parameters to build predictive models of allograft fibrosis. We would also want to use MpMRI to predict renal outcomes, such as graft loss or loss in renal function a year after imaging. And we would integrate the MRI parameters with potential laboratory and urinary biomarkers of fibrosis. These methods can also be translated to native kidney dysfunction, such as chronic disease or diabetic nephropathy. I would like to thank the Body MRI group in tMII, my mentors, Dr. Bashir Taouli, Dr. Sarah Lewis, also my mentor, Dr. Madav Menon in the Department of Medicine and Transplant Nephrology, and Dr. Fadi Salem, who did all of the pathology assessment for the study. And thank you for your attention, and do you have any questions?
That was an outstanding presentation. Thank you very much, Octavia. Any questions from the group? I had a quick question. As we all know, motion can be a big problem in abdominal imaging. Did you find that there was any differences in your findings when there was correction for motion as compared to no correction?
Yes, actually, so for the IVIM data, I did co-registrations, and I did find that the correlations to pathology improved after correction. For BOLD and for T1, these were acquired under breath hold conditions, not under free breathing. So then I didn't do motion correction. And for DTI, there was built-in motion correction. I could examine or dig in further into motion correction for DTI.
Thank you very much. I'd like to present you with a certificate. Thank you.